In this chapter, we'll look at the general survey, your overall initial appearance of your patient, and how to take weight and height. The general survey is really just a study of the whole person on first appearances. It covers the general state, physical characteristics, and overall impression, how the person behaves, their body structure, their physical appearance, their mobility status, their behaviors, their facial expressions. It's your first impression of the patient. We look at their age. Do they appear to be their stated age, or do they appear to be much older or much younger than their age? Are they developmentally appropriate for their gender and age? That goes along with childhood, the developmental stages of childhood. Level of consciousness, are they alert, oriented? Do they ask questions and respond appropriately? Is their skin color, even tone, and pigmentation consistent with their genetic and ethnicity background? Is their skin intact, no obvious wounds or lesions or rashes on their body? Are their facial features symmetric with movement, with smiling, with talking? Their eyelids, are they level or are they droopy? Their overall appearance, let's look at how they are present in any absence of distress. So they have even and unlabored breathing, they're pleasant mood, and is there anything that is abnormal? In the textbook, there is the right hand side, it says abnormal findings, and that is the pink box on the right hand side of the textbook that will describe what is abnormal findings for your patients. And if you know what is normal, then you can definitely pick out what is abnormal. So does their height appear with a normal range for their age, genetic heritage? For example, if you have an 18-year-old who is the same height as an 8-year-old, there's probably something abnormal there. We need to investigate the growth stunting or problem there with the growth. Nutrition, do they look like they're normal weight for their height and body build, or are they malnourished, or are they obese? How is their body fat distribution? Do their body parts look equal bilaterally? Are they in relative proportion, or is one leg larger than the other? Does the person stand comfortably and erect, which means upright, and appropriate for age, or do they have kyphosis going on or lordosis? What's the position of the patient during assessment? So their position, and then how are their body build and contour? Are they proportional? Is there any deformities? Then we will start doing some objective data, and that is where we can have them walk back and forth. We can look at their gait, that's their walk, how their foot placement is it smooth, even, well balanced? Is it symmetrical arm swings? Do they have full range of motion for their joints? Is it smooth and coordinated, and no involuntary movement noted, like tremors, that sort of thing? Their facial expressions, do they maintain eye contact? Are they appropriate to situation? Is their mood and affect, are they pleasant and cooperative? Or they articulate their speech very well? Can you understand what they say? Are they clear? Are they slurred speech? What is their speech pattern? Are they fluent in the language they're speaking, or is it English as a second language? Are they talking really, really, really fast, or are they taking a really long time to get the words out? So that all means something on the other side. Do they make clear sense? Do they convey their ideas clearly? Are they, or do they communicate in their language easily, or do they need an interpreter? Do they dress appropriate for the climate? Are they appropriate for the season? Do they look clean? Do they look well kept? Are they wearing clothing appropriate for their culture? Do they have personal hygiene? Are they well groomed? Do they have an odor? Are they appropriate for their occupation and their socioeconomic group? So, Of course, teenagers, they dress and smell a little different than adults. So we would take that into consideration for their developmental age. We use standardized balance, which is that old-fashioned slide across scale, or we can use an electronic digital scale. We tell the patient to remove their shoes and outdoor clothing and empty their pockets before standing on the scale. If we're going to do daily weights or consistent weights, we tell the patient to take their weight at the same time every day. Usually first time waking in the morning after going to the bathroom is the best time to take a daily weight. And in the hospital, we would shoot for the same time every day as well, because what we intake during the day influences our weight drastically. We record weight in kilograms and in pounds, depending on your facility procedures. Then after we record their weight, we will look at it on a height and weight chart to see if their height and weight coordinates with the range appropriate for their height and weight together. So we also compare it to previous visits and ask if they've had any recent weight loss that is explained by successful dieting or unintentional weight loss. Usually weight gain reflects an overabundant caloric intake on a regular, consistent basis, and that's usually where weight gain comes from, unhealthy eating habits and a sedentary lifestyle. When we take height, we use that wall-mounted device with a measuring pole on the scale. We extend the headpiece to the top of the head. They should not have shoes on, look straight ahead, and then we can ask them to step off the scale and read the height down there where it comes out of the scale pole. The BMI, the body mass index, is a practical marker of optimal weight and height for an indicator of obesity or a protein calorie malnutrition in a general sense of patients who are not extremely athletic, okay? So for the BMI weight chart, underweight would be considered less than 18.5 kilograms. And then for a score of obesity begins at a BMI of 30 or higher. And here you can see the BMI chart. Now, take this with a grain of salt because it doesn't help evaluate patients who are athletic or who have a lot of muscle. So, for example, if I have a 5'11" male who weighs 220 pounds, but they are a bodybuilder, they're probably solid muscle in who knows, 14% body fat. So that would not be obese at all. But if I stuck them inside the BMI chart, they would be considered obese. So we have to use this as a guide and not really a diagnosis tool. A better way of looking at obesity is the waist circumference. So this assesses the body fat distribution as an indicator of health risk. Excess abdominal fat is an independent risk factor for disease, over and above that of the BMI index, like we just said. Waist circumference is measured in inches at the smallest circumference below the rib cage above the iliac crest, which is the top of your hip bone. So the waist is measured right below your rib cage above your hip bone at the smallest area. That's the waist. Your hip circumference is measured in inches from the largest circumference around your buttocks. And then the measurement at the end of normal expiration. So we don't want to take these measurements while they're taking a deep breath. It should be at the end of their breath. Now, for developmental competence, we have to treat infants and children different than adults. We interpret this based on their age and developmental ability. Behavior and caregiver bonding is also noted on how they behave in the general survey with each other. We get weight and length and height. So infants are measured in length. We measure cephalocaudal, so from the head to the bottom of the feet. As you can see in this picture down here, we would measure from the head to the bottom of the feet the length. That would be that baby's height. And then for children who can stand, we would measure their head. With this scale, we'd put that up and measure the top of their head. Then we'd have them off and we'd look at the measurement right there at the bottom. We look at the CDC growth charts for appropriate growth and development, for also head circumference and chest circumference, usually for infants and small children. For aging adults, they have consequences of aging changes related to posture and gait. Their height can decrease and their weight can increase or decrease. It just depends on each patient. So with aging adults, you may have a posture that is kyphosis. That is the humpback one, where they're kind of leaning over, hunched over. That's kyphosis. Their gait can be slower, more unsteady. Their posture is that kyphosis posture. And then their weight can decrease, or it just depends on each patient, I believe. Subcutaneous fat loss from the face and periphery, so that makes their face go down farther, and they may carry more weight in their abdomen and their hips. Abnormalities in the body height and proportion. There's genetic and hormonal things that can affect growth and development. Dwarfism, hypopituitary, gigantism versus acromegaly. You'll have enlarged hands, enlarged fingers in this one. Anorexia nervosa is the actual mental health disease for not eating, so anorexia nervosa, versus the word anorexia just means without an appetite. The anorexia nervosa is the mental health component of that disorder, versus bulimia nervosa, which is intentional vomiting, which can both of these affect weight gain. They will be in a weight loss stage, in an under malnourished stage. There is Cushing syndrome and other things related to thyroid. And Marfan syndrome is another abnormality with unusual distribution of arms and leg lengths. And this case study will be presented during your class session, so you can read through this and decide what you think the general survey would be for this case study.